Welcome to Innersight, Health Optimization with Rudy and Shaun.
Okay, here we go. Shaun, podcast number 26. We are getting pretty professional at this now. So, and talking about professionals, we've got a professional here today. So when we do our Innersight program, we talk about cancers. And this one today is very important. So colorectal cancer. Excellent. Yes. I think if we speak of cancers in general, at the moment we can screen for a couple of cancers only, and colorectal is one of the ones that we can screen for. And we need to use the tools that's available, but we also need more information on the subject, and that's why we've got the specialist here today. Yeah, so I asked one of my friends, abdominal surgeon or general surgeon, who must we ask? And he said, without a doubt, we must get Jaco. So we've got Jaco Burtis, specialist colorectal surgeon. And Jaco, thank you very much for coming in. And he works in Durbanville Medical Clinic up in the northern suburb of Cape Town, not too far from where we are. And he trained at BITS and super specialized. And you've been in private practice for about 2-3 years now. 3 years now. Yeah. Brilliant. Thank you for joining us. It is still one of the cancers that scare us all, and I think for two reasons: the screening. So a lot of people. So we're going to talk about how that works, and then also, I think you see it a lot, but we see it as well. Is probably the one death you do not want is a colorectal cancer that goes bad. So yeah. So maybe as a start, we talked just before we started that it is getting more and more to be a cancer that we should know about. It's moving in the younger direction. Maybe you should just tell us a little bit what you're seeing in private practice.
Yeah, so I mean, as you said, it's a cancer. I'm saying here, but it's a cancer that's becoming more and more prominent, and it starts off prominent already. If you look at the cancers in the global landscape, I mean, we all know about breast cancer. We all know about Movember and prostate cancer, but we all forget about colon cancer. And whether you're a guy or a girl, it's your second most likely cancer because you're only one of the other two. And it's the one we all avoid. So looking at our global landscape from an epidemiological point of view, it's also the one that's on the rise, big time. We don't really know why, but we know that it's getting younger. The age group's getting younger, and when they present as a result, it's more aggressive and more advanced because it's an age group that we're not seeing as often. I can hypothesize onto why, but yeah, it's definitely one to know about, as you say.
So just a question on the increase of incidence of the colon CA. Do you see it in the older age as well, or is it the added numbers in the younger age causing the increase? Do you see a stabilization in the older group, or are they also on the rise? Because we know that the younger group are on the increase.
So honestly, I the last time I looked at the stats was 2 years ago, and that was the younger group that's on the rise, and the older group is just still there. It hasn't dropped off.
Yes.
There's an increase in incidence because there's a younger group coming into the fore. So it almost appears to me like the age group is shifted to the younger. We've got a saying in this colorectal world: if you live long enough, you're going to get colon cancer. It's almost a statistical inevitability through aging. The question is just how long time do you have until that switch happens in the colon where it changes to cancer? So when the curve shifts left, you see the overall increase.
And that's obviously the blind spot, because traditionally we don't look for colon cancer in the young population.
Yeah.
I think maybe one step back, let's talk about colon cancer. What is a cancer in the colon? How does it progress? Is it, from just general, so that the general population understands?
So generally speaking, colon cancer is a genetic mutation in the colon cells. These are relatively fast dividing cells, and it's a mucosal surface. And as they undergo genetic mistakes, they majority of them will progress into a polyp. And then from the polyp, an adenoma, it progresses into a carcinoma. So there's this relatively predictable sequence of adenoma, carcinoma, carcinogenesis.
So for our listeners out there, polyp looks like a skin tag, or if you see it.
Yeah, so in the same way as you say a skin tag, you might have a mole on your skin, which is an abnormality on the skin cell growth. The same thing can happen in the colon. The only difference is in the colon, it's very hidden. So when those polyps happen, you don't know about them. And there's about a 5 to 10 year plus minus lead time between those genetic mutations happening. And my analogy is always it's like climbing a ladder. The first step up the ladder, you've got an adenoma, then it becomes a high-grade adenoma or a high-grade dysplasia, in other words, very abnormal. And then from there it goes, another switch will happen where it stops dying or it divides more actively and then it starts spreading. So within a cell that's already abnormal, it's more prone to get more abnormalities. And that's how this sort of vicious cycle accelerates into the cancer.
So the longer you leave it, the worse the outcome.
Yes. Or the more likely it is to become cancer.
So it is quite almost, you can almost use the analogy of the skin. You start from the outside and it grows in, and the deeper it grows, the more it's likely to spread.
Well, I mean, the definition of a cancer is invasion of the basement membrane. And I mean, the colon's cellular layer is 1 cell thick. So it's not that it goes deeper. The minute it goes deeper, it's a cancer. But it does grow. It gets thicker. It enlarges in its size. And as it enlarges, you've got more cells that are abnormally dividing. And so your statistical eventuality becomes a cancer. And the determinants are really how fast are they dividing and how abnormal are they to start with.
Okay. We do not screen as such in our Innersight assessment, but we almost guide people to say they have now got to go. So, I mean, we are in the thinking pot of 40 is the new 50. So, are we correct, or should we screen even earlier?
So I can tell you what the global stats say. So up until about 10 years ago, America was saying screen at 50. And they noticed that in the group they were screening, they were having people live longer. So their screening was conclusively making people live longer. And we can talk about the reason for that in a while. But then they noticed that there is in their statistical studies, the age group 45 to 50 is now showing an increase in death or a higher mortality rate as a result of colorectal cancer. Now, I think it's because that curve was already shifting. But then they realized by dropping the screening age to 45, there is a survival benefit shown, and they implemented it. So now to your question, is 40 the new 45? I don't think we're quite there yet. But as we're saying, in my private practice, I think I do have a selection bias that says I'm living in a relatively affluent area and I'm new to the private practice, hypothetically in a 2-year cycle. I definitely see younger cancers. I'm seeing a lot of patients under 40, even in their 20s. So, and you would think these are all mutations that, family cancers, but they're not. I've seen quite a few that are sporadic cancers in their 40s. So if you're thinking, okay, a cancer at 40 means we should have probably screened that patient at 30. So I think the question is not should we be screening? The question is at what point does the cost-benefit balance break even?
And especially for us in South Africa that pay for our medical aids, because the medical aid still pretty much thinks of 50 definitely, but they are moving towards a 45.
I find it very easy to justify 45. I think if you've got the American population conclusively guiding saying 45, South Africa, if you're in the private sector, 45.
And let's talk risk. So we see a lot of people come through and want to know, but should I go for a colonoscopy? And then you say you are at an age where it's probably necessary, but is there
or are there people earlier than 45, high risk, that you want to see earlier? Is there something that makes the red light go off for some people?
So to me, the ones that I see in practice the most is the change in bowel habits. The person who's had a normal, regular bowel habit their whole life, and suddenly it's changed. Don't ignore that.
So both sides, diarrhea or constipation?
Any change.
Okay.
See a change.
Okay.
That's a warning flag. And it's the kind of thing that you should have investigated, because it's either metabolic or it's plumbing. It's one of the two, and both need to be looked at. And the last thing, and the other one is new bleeding, new blood. I mean, it's easy to blame a hemorrhoid, but that should be almost a diagnosis of exclusion, and it should be a diagnosis made by a clinician, not something you brush off, so to speak, as a hemorrhoid, because the number of disasters like that I've seen is devastating.
And a clinician that actually has done some type of examination, not just call it across the table to say it's probably a hemorrhoid. So you need to go look or feel or do some type of investigation.
Exactly. Yeah. And it, I'm quite lucky again, my drainage area, we've got a very competent GP network training to us. And it's amazing how many times I've now diagnosed the young cancers, because the GP said they have hemorrhoids, but they don't look like the ones that are bleeding. And then you go and do a scope, and it's a young patient, and then you find something. So those are my two big flags: change in bowel habit and bleeding or blood. And then from a GP point of view, or from a doctor point of view, the unexplained iron deficiency anemia. Those are the three big ones. From your own history, it's the cancer history. Is there cancer in your family? Are you a high risk? And I don't think it's a fair thing to say, do it yourself. I think see a GP or see someone who can actually go through your history and say, okay, you're at higher risk for colon cancer, and because of that, you should be going 10 years prior. So in other words, 10 years earlier than the family member's cancer.
No, so I think also if you fall in the high risk category, in general, most people will know. I mean, my father had a cancer. I've got some genetic condition increasing the risk. And I think most of the GPs will be on top of that factors and guide you in the correct way. I think the blind spot is the younger people. And it's so nice that you've mentioned that if there's any change in stool habits or any bleeding, that's a warning sign. So that's something practical that people can use and go to the doctor if something like that happens.
Yeah.
And we also had Prof. Vernon Lowe on the Iron podcast, and that was one of his things. Even in young ladies, where the bleeding is not that much in the menstruation, that you actually pick up that there's something in the bowel. So while we're talking about bleeding in the bowel, is it worth screening for blood in the bowel, or? I mean,
that's a complicated question.
Yeah, I'm lost here because we have done it in the past and we didn't find it that useful. So we rather say go for your colonoscopy and have that test, because we feel we might miss it.
But maybe we can step back and then go through the steps of what's available.
Okay, so if you're going, there's two patient groups. The one is symptomatic. They know there's blood. Then it's no longer screening. Now you're doing diagnostic investigations. If they can see the blood, if they know there's blood, there's no point in testing for it because it's there. Then you go to the next step, which is a colonoscopy. The question comes, are you screening? Now, the screening group is by definition a healthy, well person that you just want to know, is there a problem coming? And that also has a division in your approach. Are you screening or are you preventing? And I think that's quite a subtle difference, but prevention is not a form of screening. Prevention is trying to avoid the disease, and screening is trying to pick up the disease early enough so that your treatment makes a difference. And when you Google or when you look for how do you find a colon cancer, you have already selected for screening of an existing cancer. You are not looking at the prevention bundle. So back to your question, should you be screening? Yes, you should be screening. I, to my patients, advocate for the prevention basket. So if you're looking at a young, healthy, well-informed and financially able patient who can get into the prevention basket, that is definitely the one you want to be in. And so I'm just going to address the screening basket first. So screening is there to try and find a cancer. Then we've got all these modalities, like do we test for blood? Do we test for cancer DNA, be it in the stool or in your blood? Or do we go do a colonoscopy to find a cancer? There, my answer is do the test that you'll actually do. Do the test that the patient will go through with. Because a colonoscopy is patients don't necessarily want to do. A stool test patients often don't want to do because it's so difficult and so laborious. And the blood test might not be quite as accurate in all the situations. But do the one you can. If you're going to do one, great. But all those tests end in a colonoscopy. If they flag positive, you should be going for a colonoscopy. So in the private sector, I find patients A are short of time. They want an answer now. And they probably want to be in the prevention basket to start with. So my recommendation is just go straight to the colonoscopy if that's your option. And the colonoscopy has two benefits. One, it's got the diagnostic approach to, it's going to find the cancer. And there it's 99% accurate. You're going to find a cancer if it's there. But the other part that really is important is in 1/3 of the colonoscopies of screening, you should be finding polyps as an endoscopist. So 1 in 3, if you're meeting the 45-year-old criteria. And in that group of patients, there I feel the colonoscopy is fantastic because in 1 in 3 patients, we're now taking out polyps, which means we're giving them a longer life, A, and B, preventing the cancer. So they're never in the screening group because they never got the cancer. Does that make sense?
Yeah, it makes absolute sense. It's actually more scary than I thought. I mean, I push as hard as I can for everyone to go early for their colon cancer. I mean, we talk about, we started all of this because we are in the same boat. We are moving along in the same boat. And I am actually one of the high risk because my dad had colon cancer that was picked up a little bit too late and that he had to have a piece of his bowel resected. But he's still alive. Yeah. So he was the screening side and then the pickup side, but he was not the prevention side. Luckily, I could push all my brothers and we are all in the prevention side now because,
it's also, I just want to say in case, so between the screening and prevention, I think part of what one needs to understand is because you need something to bleed or to actually shed DNA material for the screening to work.
Exactly.
Whereas in the earlier stage, those tests will be negative.
Yeah.
And that's why it's the prevention versus the screening. So it doesn't help you do the screening test and think you're going to prevent it.
Exactly.
Because you won't pick up any issues as such.
So I like to flip it on its head and say, if you have symptoms and you just want peace of mind, then you can do the screening test because we know that we've established that those screening tests are good for finding really worrying signs. But the corollary to that is if you have symptoms and that came back positive, you'd probably go for the colonoscopy anyway. So again, we have such an easy route to colonoscopies in South Africa that to me, it's very easy to advocate for them.
I must say that 1 in 3 is a scary
30%. Yeah, and I looked at my own stats on the weekend in preparation for this, and it really is 30%.
And in general, I think all polyps will eventually over time.
No, so it's not all.
Okay.
I mean, by implication, then 30% of those patients would end up in a cancer, and our stats are not quite that high. But depending on the grade, the size, and the underlying morphology, like what type of polyp it is, that determines its prognostication for the cancer. The problem is if you do the scope, it's there's some guidelines, but it's very difficult to conclusively say, okay, this is a high risk or this is a low risk. So you want it out, and you want it under a microscope and not in your colon. And
No,
then you can
absolutely. I
decide.
agree. If I'm the patient and you tell me afterwards there was a polyp, but it looked okay, no, I would really want to know the histology on that.
So let's say we're one of our listeners and they are now 45 and they want to be screened. How does that picture look? I mean, or screen preventive. So they've got no changes, but they think they should have their first colonoscopy. So literally pick up the phone and say they want a colonoscopy, or do they go to their GP? Or
So my personal feeling is you should probably be seen by a clinician before you are booked for a colonoscopy. And the reason for that is actually the worst part about a colonoscopy, and that's the prep. So you get given sodium picosulfate or a type of pico prep. And that means you flush the bowel out the day before in preparation for the actual colonoscopy. So the colon's empty. And that's a physiological insult. I mean, you take a bit of a knock, the patients are slightly dehydrated, they tend to be a bit nauseous, and the electrolytes might be thrown out of whack, for lack of a better word. I want a clinician to say, that's safe. So in our practice, I don't see all my patients that I book for a colonoscopy, but they have been seen by a GP in our area that we trust that says, this person needs a colonoscopy. I'm willing to prep them. Would you mind doing it? And then we'll see them on the day after the prep and actually do the scope. So the referral network is usually via your GP, unless you're already known to a surgeon somewhere who's willing to do it.
okay. Yeah, so and it'll be fine for us to then see them in our clinic and then refer on to you. Okay.
A question on the colonoscopy. So that's a gold standard because you can diagnose, you can prevent, you can treat all at the same time. So that's obviously the Rolls Royce. You want to do that. But there's other tests that we can do, and the question about the video capsule or a CT colonoscopy and things like that. I assume with the CT you won't pick up like early lesions, or would you still see them because you can't see them? You see it on a scan, so it's.
I'll be honest. The CT is a great tool, and it's on the one hand it's almost safer, and that there's no perforation risk, much lower perforation risk. Having said that, a flat polyp, like the sessile serrated polyps, or sorry, terminology, but a flat polyp that doesn't stand up on the mucosa, you're not going to see because a CT, it's amazing how they can reconstruct and they almost give the radiologist a colonoscopy view, 3D reconstructed as they go through the colon. But it's looking for mucosal abnormalities. So on the one hand, they have false positives. So if something's stuck on the mucosal wall, it looks like a polyp, they're going to call it as a polyp, and you have to go for the normal colonoscopy to double check. And on the other hand, flat polyps, which are also some of the most dangerous polyps, are often missed. So you have a lower prevention and a higher false positive on a CT colonography.
Okay.
Other modalities, depending on the modality, will decide how accurate it is. CTs in general, my thumbs up is anything bigger than a centimeter you should see on a CT, but less than that, smaller or less likely. I'm trying to think of others, like a barium enemas and all the rest. They kind of follow the same mentality, but even lower sensitivity and specificity.
So that's really for the person that cannot get to a colonoscopy.
Yeah, look, I mean, colonoscopies are not without their problems. And so it's always the ironic thing of it's a technically difficult procedure and you need to have been trained, and there are risks to it, and there are some patients that are high risk. I quite like a CT colonography in the patient who's got lots of abdominal adhesions and severe diverticulosis. 1 or 2 patients I've had where it feels unsafe to do a colonoscopy because they've got so many high perforation risks attached to them, that the last thing I want to do is try and prevent a cancer and make them worse because of the colonoscopy. So I think that's where the individual endoscopist's impression comes to the fore, and it's why you actually need to be seen by a clinician prior to a scope. It's not it's not a dental appointment where you phone and make appointment. You have to be seen first.
And that's probably one of the things why AI won't take your job is it is technically difficult, like you say. And like with most things, like a mechanic of a car or someone fixing your roof or whatever, everything that's technical has got a good one and a bad one. So, and as you say, you need to trust the system that's trained these people that it will be good.
So there's also the component behind the sort of AI, as you say, that brings me to that polyp detection rate. So it is, when we look at our stats as endoscopists, we want to know, how often did you get to the end? Like, what's your cecal intubation rate? In other words, how far did you get to the very end? What's your ileal intubation rate? In other words, how many times did you go into the small bowel at the end of the colon? And what's your polyp detection rate? How often are you picking up a polyp? And did you get the polyp out conclusively afterwards? And lastly, what is the rate of cancers after your colonoscopies? Like, how many cancers did you miss effectively? I haven't been in private practice long enough to have a cancer detection rate, a post-colonoscopy cancer rate, but I can tell you my stats are on international standards, where we say 99% of the time you must reach the cecum. If you need to get into terminal ileum, you need a 99% ileal intubation rate as well, but we don't routinely do that. So mine's about 25%, which I think is standard of the total. And you need a 30%, as I say, colonoscopy polyp detection rate. Now, I know as you start out, you are nowhere near that. Nowhere near. Which is why you need a guy standing next to you who will show you the tricks and help you get to the cecum when you're training. And that's why it's a mentored training program. And it's part of the difficulty in South Africa is just, a lot of the oaks are self-trained. So they go through a bit of a learning curve throughout the course. And then the second component to that is, okay, you found it. Did you take it out? Did you take out the polyp? You need a trusted endoscopist. That's
absolutely. And I mean, I want to come back to where this ends, because I mean, for us as doctors and working with this all the time, understand where this is going. If we say, but you pick up a cancer and you don't pick up a cancer, but I want to paint the picture to someone that if a cancer is missed, where this goes. Because I mean, like my dad had a piece of his bowel removed, so he was lucky. It was picked up and it was not through the muscle layer, so then it hasn't spread. But I mean, the picture after that, the grades of cancer, then maybe just describe what happens if it spreads and it's too late.
So colon cancer is one of the few cancers where the word too late is very rarely used, to be honest. I like to say in our practice, it's the minority where we're saying it's too late. And the reason is because it's a relatively slow growing cancer when you compare it to other cancers. But its natural history is it tends to grow, it goes through the bowel wall, and then as it goes through into the muscle layers, it tends to spread via the bloodstream, and it tends to spread via the lymph nodes. So you have local lymph node spread, and that follows the arterial supply, so next to the arteries. And the blood supply goes to the liver. So you tend to find the majority of the metastatic spread either in the lymph nodes or in the liver. And that kind of, for me as a surgeon, is quite lucky, because the majority of my colon cancer patients will be in stage 2, stage 3, stage 4. They're not stage 1. And in that, by implication, means I still have an operation I can do. I can still go get those lymph nodes in the majority of cases. And we've got really good liver surgeons who almost go for everything. As long as they leave a functional amount of liver behind, they'll chisel and cut everything they can. And that's left us in an amazing situation where even the stage 4, where, in any other cancer, if you hear the word stage 4, it's a terminal prognosis, we still have a reasonable survival. I wouldn't call it a perfect, but we really go for those cases. A couple of cases come to mind this year where we've taken out liver, pieces of the liver, pieces of the lung, done a full resection of the colon cancer, and 8-9 months after all of this with the chemo, we can say the patient's in remission, which I don't think many other cancers offer you. No.
And still, early colonoscopy is much better than all those things down the line. So, I mean, a lot of these people end up with colostomy. So in our language is then layman's language. You actually bring the bowel out onto the abdominal wall, and you poo in a bag.
Yeah.
So and I mean, just it's uncomfortable. It's just not where you want to end. So, but I want to sketch the picture that people see. Because, as you said earlier, people don't want to go for a colonoscopy because they don't want to have the bowel prep. They don't like lying there and let someone put them half to sleep and camera up the bum. But that is so much better than the alternative of waiting too long.
Yeah. So, there's also variations in colonoscopies, but in a well-controlled, experienced center, the worst part of a colonoscopy is the day before, by far. It's the picker prep that you have to take that makes you run to the toilet every few minutes after you've had it. The actual colonoscopy is a breeze by comparison because it's done with an anesthetist or doing the sedation. They're using the same drugs that you get with any other operation. So you go to sleep and you wake up in the recovery room afterwards. You haven't got any cuts on your abdomen or any other cuts, so you feel fine, maybe a bit bloated, but relatively hungry and usually in good spirits. So that's a way better experience in its entirety. And the majority of the patients that we have in our clinical practice are nervous before and relieved after. Relieved not because we've even spoken to them, they're just relieved because it was such a benign procedure in its entirety. So I think the important thing is it should just be managed well.
And the other thing is, if you had a normal colonoscopy, then it's there's a time period that you don't need another one.
It's
The 10 years, according to the guidelines. Do you still feel 10 years is adequate? It's all that question mark around it, but I suppose 5 years at least.
It's where that balance happens of screening versus harm, cost versus benefit. If you want perfect screening, you should be doing a weekly colonoscopy. That's your sample rate has to be ridiculous. But if you're talking from a scientific point of view, the faster your screening, the shorter your screening time, the more your pickup rate, the less your rate of risk happens. So that sweet spot is a public health question, and it's determined by what can the area doing the screening afford, what can the person afford, and what can the system allow. Okay, so most of our guidelines that we follow are working either in the American or the European system. The European system, I don't even think can manage a 1 every 10-year colonoscopy, which is why they've resorting to alternative screening methods as a way to filter. The American system is way more defensive with a much higher private sector, so they can afford a once every 10-year screening system. The patients might not be able to afford it. South Africa, we're sort of in between. Our private healthcare system can afford it. Often they don't pay for the whole thing, which is quite frustrating, but they can afford it. Our government sector can't afford it at all. So we don't even screen in our government sector. The government sector has a wait for symptoms and then address it.
Yeah. And I want to come back. I mean, all three of us that sit here have had a colonoscopy, and I agree with you. It is exactly that. So the day before is probably the worst, and maybe putting in the little drip to give the medication, but you literally don't know about it. And in that sense, for me, is getting someone through that door the first time is your biggest hurdle, because I've seen so many of the people that did not screen and then be caught with a cancer where they should have been in the preventative. And I want to stress this, that it's actually not that bad to go through that first colonoscopy, but they have to screen early once, and then that lag is probably academic. But if you've had one negative, then I mean, it's like girls going for their first mammogram. I mean, you're relieved after. It's like everything is okay, or I've found something, but we're going to check and it's probably going to be okay. And then your follow-up starts. But if you haven't had that first one, you've got this axe hanging over your head. Are you waiting too long?
Yeah.
And am I getting this correct?
No, definitely. I think the first colonoscopy is also the most important because it stratifies your risk. It's the one that decides your survival, and it also prognosticates. So if you do the first colonoscopy at 45 and you find 20 polyps, big polyps, that puts you into a familial polyposis syndrome, which means your long-term cancer is now 100%. Like if there's hundreds of polyps, you're in trouble. You would have never known you're in trouble until you did that scope. And it's amazing to me how many polyposis syndromes I'm picking up as the first scope in the family. And the rest of the family died of old age in their 50s. It's just, So from a screening point of view, I mean, I very strongly advocate for the colonoscopy, but it's also from a stratification point of view. It helps you know your risk. So we've got quite stringent guidelines, and we're guided by the US and the Europe on what do you do when you find now a polyp size, type, a number, and that determines how quickly we should scope again. Because in theory, we've cleared you now. There's no more polyps now. If you develop a cancer now, it's a sporadic, or it's developed in the normal colon wall, which happens, but it's much more rare. So the more likely option is now that you're going to develop new polyps. And the question becomes, how quickly do you make polyps? Because if you've got one sample, you have no idea what your time development was. So there's a risk model, and then they say, well, okay, you've got 10 polyps. We should probably see next year. Next year you come, no polyps. Okay, we can push it to 3 years, or we can push it to 5 years. And so we're always trying to extend the period back to 10 years. But the idea is to get rid of all polyps.
And that's the first colonoscopy that guides you through the process.
Very much like picking up something on a pap smear, and you stretch the time. So, I mean, girls go yearly, and then they can do 3 yearly, then 5 yearly, as their risk decreases.
Yeah.
So,
I want to go right back to the beginning again. And why? And I don't want a straight answer, because I know like these things are difficult to answer. But why do we see this rise in the young people? Is it environmental? Is it diet? What do you? I mean, we've got opinions on it, and it's not necessarily proven in literature. But
so
the question that I want to ask you, I mean, you read it, you see, okay, there's an increase in risk if you're obese. There's an increase in risk if you a type 2 diabetic. There's an increase in risk if you drink a lot of alcohol. So there's all these other factors other than just the normal ones from the polyposis and the genetics and everything else. Do we think that that's the main reason why we see this younger age group developing more carcinomas, or what's the feeling in the field?
So the modern sort of theory goes according to, is focusing on what we call the microbiome, which is the rainforest of bacteria in the colon. I mean, if you had to do a cell count, human versus colonic bacteria, we're actually just bags of colonic bacteria. They're exponentially more than we are in number of cells. And the constituents of those bacteria and what is feeding them, what they're feeding on, what they're producing, and that cycle or biocycle inside the colon is probably the driver of a large amount of human pathology, to be honest. And the wall containing this microbiome is a very thin wall. And that's sort of the war zone of inflammation versus just normal mucosa. So to your question, I think our diet, our lifestyle, our hormone levels, our BMIs, our weight, everything comes down to our diet, and because your BMI and your weight, it's all to a large degree that colonic content, and also how fast it does go through. So each cell on that colonic mucosa, how long is it sitting there exposed to carcinogens, and what is the concentration of carcinogens in the colonic lumen? And when you take it down to that sort of very scientific, call it statistical analysis, anything that makes your colon go slower increases your exposure time. Anything that increases the carcinogens in the colon increases your exposure time. So things like a high BMI, being overweight, your colon's going to be working slower because that patient is less active, so their colon is slower, so they have a higher possibility of mucosal exposure. I think the reason, to your question, why we're seeing a spike now, I think we're in an epidemic of processed foods. I think we are hyper processing our foods because that's what's cost effective to a company. It doesn't make sense to be unprocessed foods. It's difficult to store, it's difficult to keep, it's difficult to transport. And in that processing, we are probably creating carcinogens and we are reducing fiber. And I think the combination is why we are seeing so much more cancer. And if you look at the American Cancer Society, they have classified processed meat as a class 1 carcinogen. And it's based on this. So red meat is a class 2, processed meat is a class 1. So to your question, if you think about how much processed meat the modern diet includes, and I think you have the answer.
It's actually amazing how that plays into all diseases. And just, looking at your diet, looking at your exercise regime and all these things can improve a lot of medical diseases, and improve heart disease, metabolic syndrome, but also possibly reduce the risk of colon cancer.
Definitely reduce. That's quite proven now. Physical activity reduces your risk by quite a large portion. It's like 30%.
And it almost fits that we talk about. The best pill that you can take is getting out of bed and exercising. That's our one thing. You can actually reduce your risk of dying early by 50% by exercising. But this is, and again, I always say we get like these little clinical pills for us as well. And that's actually, I didn't know that the bowel actually moves quicker with exercise, which is...
You should ask a runner.
yeah, which is great. I mean, and that is exactly why you do these things, is let it move quicker through. Yeah, amazing. I'm actually stumped with that. Okay, yeah, it's interesting. I'm just wondering with the cyclists. I like cycling and how that works. Interesting.
Maybe sitting a bit more.
Yeah. Yeah. Okay. Jaco, we want to bring it back to if someone wants to book with you. So we now know, and obviously you're giving us your time and your expertise. So they should maybe go and see one of their clinicians and find you. You've got a website.
Yeah.
So and we will link it to in the podcast and to the bottom of the YouTube page. And is there anything you would want to tell people? So because you do a lot of consultations where people sit in front of you, but that you have to say a lot. So sometimes you can say, okay, but listen to the podcast. I've done this. Is there something you would that you haven't said that you would want to say to people beforehand?
To be honest, I think the important part about screening is it's a healthy population. I don't think you should look at a screening group as being sick. I think that's the first thing, that you should probably be in the screening bundle because you are well. If you have symptoms, then don't hide them, but also prioritize them in your clinical environment. In other words, it doesn't help a patient go for screening, but they actually have symptoms. Because I approach patients with a screening environment, you're not in a rush. I don't need to see them in the next 2 weeks or the next week as a rushed case. But I see a lot of patients being funneled through the screening process. And then when they finally get to me, they said, "Doc, I actually wanted to tell you I've got these symptoms." Rather tell those symptoms up front so that you can be prioritized, because we really do prioritize symptoms. And that's probably the only thing I can actually add to this contra, is there is screening and there's diagnostic, and those are very different. And your priority and your approach, everything changes when it's diagnostic.
Yeah, just to bring back what you said earlier, so the change in bowel habits or seeing blood, that's diagnostic.
Exactly.
That is someone that needs to be rushed through the system, not rushed, but need to be seen earlier.
Yeah. I mean, I often hear people say weight loss, and funny enough, weight loss is not really on the cancer list of colon cancers until it's really late. And in fact, it's quite the opposite. Patients often gain weight first and then lose weight. And that's just because of obstructive symptoms.
Yeah.
So that early obstruction actually causes weight gain, and then later on. So yeah, weight is not a thing. It's the change.
Okay. Excellent.
No.
Yeah, I must say, the 30% positive rate of polyps is quite scary. But I think we've concluded that it's actually a non-event going for a colonoscopy, and I think people can feel like a bit more relaxed about it.
Exactly. So,
and once you've had your first colonoscopy, then you can talk about what's happening next. But in most cases, they'll only need to see you in 10 years or afterwards.
2 out of 3.
2 out of 3.
Again, thank you so much for coming in. We said that the time will run with us, because we always think it's going to be like 15 minutes and then suddenly it's almost an hour. So thank you for sharing with us. I certainly learned a lot, and I hope the people that we see and ask to go for colonoscopies will end up doing the right thing. So we try and push them and have that first colonoscopy. Thank you so much.
It's only a pleasure.
Thank you. Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.